So thanks a lot, everyone, for joining today. Really appreciate taking the time out. So this is the first in a series of 3 webinars that Redmoor are doing in collaboration with At Scale. And this is the first one that we're doing on the foundations for integrated neighbourhoods. So it's setting the stage, the why and the how of neighbourhood working. So just to start with a bit of housekeeping. So we are going to be recording the webinar today. So any videos and microphones have been turned off while we go through the presentation. However, if you've got any questions throughout, if you could use the Q&A section in Teams or the chat, and you can add questions there. So if you haven't registered for this section directly, if you joined via a link that was shared by someone else, please ensure that you have your email address and job title in the chat. And this is so that we can make sure you're invited to the D&T network if you're not already a member. And this is where you can access the recording and the other information and assets that we'll share after this session. So today's presenters, so we've got myself, Matt Sweeney, and we've got Claire Temple from Redmoor. I'm also joined by Rachel Edwards and Alice Benton from At Scale. And we've got a number of special guests. So we're joined today by Kamal Bahia, Integrated Neighbourhoods and Regional PCN Development Lead for the South East region. Dr. Bharam Kumar, General Practitioner Partner and Clinical Lead at Bharani Group Practices. And also Anita Howard, who is the Integrated Neighbourhoods Programme Manager for South Cambridgeshire and Royston. So they're going to be sharing their experiences with you. So we've got an action-packed agenda. So we're going to be looking at the foundations for integrated neighbourhoods, including how it links to current contracts, expectations and guidance, financial considerations, and sharing those experiences from our speakers who've already started on this journey. And then we're going to try and make sure that we have about 15 minutes at the end to answer any questions that you've got. So the aim of this session is to help you understand the foundational building blocks for neighbourhood working. So by the end, we want you to feel more confident about where to start, how to plan, take early steps, and build good working relationships with other local services. We're going to tell you how to access free resources that can help support you. Everyone from primary care who joins today is also going to get free access to our digital and transformation hub, which includes assessments, action plans, toolkits, and practical guides to help you move forward with particular sections around preparing for integrated neighbourhoods. So just a reminder, this is the first of a 3-part series. So this is the first one on foundations, but we've got 2 more. One on the 12th of November around sort of building neighbourhood services and partnerships. We'll also be looking into population health management and getting more involved on that side. And then we've got a 3rd webinar on the 2nd of December around providing value and managing demand as well. So I'd encourage you all to sign up from that if you get value from today. And this webinar is brought to you through our D&T network. So the D&T network came to life in September last year. And the intention was to connect everyone across healthcare that's interested or involved in digital and transformation. So we've got a forum, we've got a newsletter, we've got the webinars that we offer, toolkits, lots of different and useful free resources for you. So we've got over 1,100 members from primary care, and we're going to soon add a community and voluntary category as well, so that we can broaden the discussion for neighbourhoods. So if you're not already a member of the D&T network, you can scan that QR code, or we'll send out invitations to all the attendees afterwards. So I'm now going to pass you over to Claire.
Thank you very much. So just sharing some results from a survey. So last week we sent out a short survey for participants to complete to guide us and give us a sense of the confidence levels that you have around neighbourhood working. So we received 26 responses from that. And it's from a mixture of practice, PCN, feds, ICBs and voluntary services. I'm just going to ask Stacey if we could pop that poll in here. I just want to get an idea of how confident you feel in your understanding of what neighbourhood health services or INTs are and what is expected of you, because from the results that we got from that initial survey, you can see that the average score was 2.8 and nobody chose 5, which was very confident. We also identified that the biggest blockers are currently unclear delivery models, limited funding or backfill capacity, and workforce limitations. So we'll hopefully be able to show you today some ways of working and talk about different delivery models that have been used that can help with funding or workforce limitations. So I'm just going to have a look at that poll just to see how we're getting on there. I'm not able to see the results of the poll. We'll let you know what that says at the end and we'll move on. I'll pass over to At Scale.
Thank you. It's great to be here today. And I think when we were planning this session, we used the results of some surveys that had been taken already, but we also kind of came at it from our own experience too, that actually there's a lot of, anytime we sort of go into a meeting or we start to talk about neighbourhood working, there's that challenge in the room. There's that question mark. Well, what are we talking about? What are people's understanding of neighbourhoods, and how can we move forward on something if we don't feel like we've got a strong kind of sense of that and a clear vision moving forward? So I think we kind of were keen to start this session with going back to what we could find in the guidance and what we can also learn from the work that's already underway. We know we're not on a blank page here for people working in this way, and that's particularly because of the work that's been happening in PCNs and the move and expansion and looking outwards to how that working from a general practice perspective can help shape and help build those relationships that are key in looking broader into the neighbourhood support for our populations. So we went back to looking at the functions of PCNs and what PCNs have been looking at working on, and then how that progresses across to the core neighbourhood components that are being shared in the guidance that's coming out nationally. So we know that PCNs have been working together to develop a shared workforce, to target their resources and efforts collectively, and those skills and functions and experience that's been established at PCN level, particularly those PCNs that are looking outwards to their neighbourhoods and their neighbourhood teams, really sort of underpin that approach to what's going to be needed in a neighbourhood working environment. So we're going to go into the details of the 6 core neighbourhood components for 25-26 in a bit more detail, so that you can see what's underpinning the vision and the work that's starting to happen. So I'll just see if I can move across. Let me see. Lovely. So just to go into these in a little bit more detail, and this is about thinking about the infrastructure in a neighbourhood community that's going to be needed to support people in their care closer to where they live and away from the hospital and care home settings that often mean that that are the kinds of care that we want to use only in the most extreme of circumstances. So when we look at the different sections, it's about having a look at this stage now and thinking about the neighbourhoods or the PCN footprints that you're operating within is the progress and the efforts that are being made to wrap this provision into those out of hospital settings. So the requirements that are set out include a population health management tool, so being able to underpin decision making and planning of services based in data and information that understands or gives a greater understanding of the demographic and need and the health need of a population. So we know there's different experience and different access to population health management tools at the moment, but this is seen as a critical component of effective neighbourhood services. Modern general practice and modern general practice access, I'm going to come on to that in a little bit more detail, but that is a key component, and we can see that from the work where we see neighbourhoods particularly growing and building from some of the work that's been happening at PCN level. There's an emphasis on standardising community health services, so recognising that a population being cared for in an out-of-hospital setting needs access to consistent and robust community and mental health services, and within that, provision of urgent neighbourhood services, so that urgent community response that's needed to keep patients out of hospital, the kind of the step up and step down type arrangements that you might see coming into place. And similarly with that, then the integrated intermediate care services, so a home first approach. So patients, when they're discharged from hospital, have got access to reablement or rehabilitation type therapy-led care in their own homes where possible. And as that team of people that is wrapping around that community starts to come together, being drawn from the health and from other public services and from the voluntary and faith and independent sector, we start to see those teams coming together as neighbourhood multidisciplinary teams working to support, in particular, cohorts of patients, and starting with cohorts of patients for where some of the impact can be most felt. So it's starting there is a kind of a template here of what we'd expect to see in neighbourhood services, and getting a sense of your readiness and the readiness of your service and your the support for the patients and the members of the public that you're looking after. There's a bit of a sense of being able to see, well, what access have we got to these components of neighbourhood services already, and where does some of the effort and the approach need to take. Now, we'll just move us on to the next slide. When we think about some of the services that might be in scope for that thinking, I've mentioned already things like community health services, so district nursing, therapies, wound care, mental health services that go along with that. I mentioned the reablement, the step up and step down services. And if your area is anything like some of the areas that we're working in and we're supporting practices and PCNs and projects in, there are really good examples of some of these services in place that have been organised around neighbourhood footprints and organised around groups of practices and populations of 50,000 patients. But it's not necessarily the case that these are fully accessible or scaled to be accessible to everyone or standardized in any way. So there will be examples that you'll be probably aware of that are working really well, but there hasn't necessarily been that ability for them to be fully rolled out and accessible at an individual practice an individual neighborhood level. So as we kind of think, so this is a very kind of quick sort of run through of the services and the expectations of perhaps what neighbourhoods will initially cover. It's starting to think about those who are involved in the establishment of neighbourhood working, the development of the integrated relationships. Where do we start? What are the building blocks? And we're looking forward to hearing from the examples that are going to be shared with us a little bit later in the presentation. But what are the foundations? Where do we start? And some of that comes with being aware of perhaps those that are taking a lead, stepping up, have got some of the ideas about how to pull some of this together. That might be drawn from the clinical directors that are already working, or it might be that you've got strong leadership coming from your ICB or place-based leads that are setting the tone going forward. But where is that leadership? What is that structure? How can you be part of it? How can you influence it? Trying to understand how that's playing out in your areas might well be a starting point, and knowing where some of the decisions and the design and planning is taking place. And then how are you being included in understanding what that shared purpose and priorities for your neighbourhood and in your place might look like? And this is kind of the focus for our first session here today, is thinking about what underpins the neighbourhood working. And as we move forward through the sessions that will come, we'll spend more time thinking about the workforce and the roles that also underpin neighbourhood working, and the data and insight that's needed to bring that to life. Fundamental to the changes that are happening, and the direction and the implementation of neighbourhood working is the relationship building, and recognizing that everybody's got a day job to do, but there's huge value and a huge value in putting the time and the effort where you can into developing the relationships that are going to be needed. And when we say about starting from cohorts of patients, looking at those patients where neighbourhood working might have the kind of the earliest or a significant impact to start with, starting small and building the relationships around particular projects really does help to, and I think we'll hear that from our speakers later, really helps to set the foundations for moving that forward. We know it's not always easy. We know in some of the conversations with PCNs and where they're looking at perhaps how neighbourhood footprints may differ perhaps from existing PCN footprints. There are sometimes tricky relationships, or there are sometimes tricky dynamics that need to be managed. But these are steps in the process for which there is support, there is ideas of how things have been solved locally, and particularly the examples we hear from other areas around where there are collective outputs and the benefits can be felt. This can really help with those relationship conversations. So we're trying to think about where people might need to feel like they want to assess their readiness for neighbourhoods, and you'll see there's a link to are you ready to lead your neighbourhood a tool here that might be worth having a look through later to determine the readiness and your appetite for leadership in your area. I'm going to move forward. So just building on that and underpinning those relationships, as we've said, is that joint vision for what good can look like, looking at where you've got some shared outcomes that you can have an impact on. So I know some projects have perhaps looked at where you've got admission avoidance, or looking at better patient experience, and developing some shared measures and resources. And I think one of the things we're going to see coming out of the neighbourhood pilots and the work that's happening in those 43 areas around the country where this work is being taken forward is some real information and ideas around some of those outputs and measures that will help to genuinely show that neighbourhood working is starting to have an impact in the areas that those working in those services and for those patients are going to want to see. So there's something about how we'll learn from those areas and how we'll help them to shape purpose and priorities as discussions start in an area. When we look at, oh, sorry, I clicked the wrong one across. When we look at modern general practice, this one played sort of close to our experience at the moment, in that we see that modern general practice is really at the heart of neighbourhood working, and it's the part of the system that's probably had the most kind of contractual change at this point in terms of moving to a model that facilitates the flow of patients into general practice and then beyond into those neighbourhood services. And part of the challenge at the moment is the recognition that whilst there are the services that are wrapping around general practice and supporting the flow of patients into other services, that point I made earlier about the lack of perhaps consistency and scalability of those services across neighbourhoods has some impact at the moment in terms of that flow of patients through general practice and the capacity challenges that some may be feeling at the moment as they implement the new models and seek to be aligned to the contractual requirements. So we'll pick this up as we move through our discussions around neighbourhoods, around how we can help general practice to be leading and at the heart of neighbourhood working, facilitating those services around it that will be so important in collating the services in a consistent and scalable way. So I think what we'll do, because I am conscious of time, I'm going to pass to Claire, who's been looking at some of the metrics around general practice and how this might have an impact.
Thanks, Alice. Yeah, so just a reminder that as you start to plan and define your neighbourhood, it's really important to understand your starting point, and this is what we mean by baselining your information. So by collecting some simple measures now, you can see what's working well and where change is needed. It also means that when you make improvements, you'll be able to clearly show the difference that they've made. So think about the areas shown here. So we've got access, continuity, inequalities, and making sure patients reach the right place first time. So an example might be that you look at how quickly patients get a response or an assessment, or how many calls or online forms are dealt with on the same day. But these kinds of measures give you a clear shared picture to build on. And once you know your baseline, you can set realistic goals and track progress over time. So I'm going to hand over now to Kamal Bahai, who's the Integrated Neighbourhoods and Regional PCN Development Lead for the South East region. I think she's coming after Dr. Bharam Kumar, who's the General Practice Partner. And they've got some really interesting experiences, and Kamal has got a really good tool for using with baselining and maturity. Thank you.
Thank you. So yeah, as mentioned, I'm Dr. Bharam Kumar, Clinical Director for Shape Primary Care Network and Clinical Lead for Bharani Group Practices, and I'm based in Slough. And just going to talk for a few minutes about how we're turning this national concept into something tangible for us here in Slough. For us, it's not about creating new structures, it's about aligning people, purpose and data at this neighbourhood level so that decisions are made closer to where people live. So neighbourhood health is the operating model of place, and for us it's how integration actually shows up for residents. And as mentioned, it's built around these 6 components: population health management, integrated neighbourhood teams, community services, intermediate care, modern general practice, and urgent out of hospital care. And in Slough, we've used this to connect existing services rather than build new ones. The focus has been on trust, prevention, and data-driven action, or as one of our colleagues put it, population before organisation. And Slough is a real-world stress test for the NHS, as it represents the challenge and the opportunity. So it's a very diverse place with lots of languages and dialects being spoken. 67% of Frimley's core 20 population lives here. And we're seeing long-term conditions like diabetes appear a decade earlier than national averages. So that's the challenge. The opportunity is that we're data-rich, digitally mature, and community connected. We have something called Connected Care, which is a nationally leading and award-winning population health management tool accessible to Frimley ICS, but we have that. And that is available to us in Slough, and that allows us to see population needs in real time. And our local council, our local partners, including the council, Berkshire Health Foundation Trust, and the voluntary sector, are all deeply engaged with this process. We've built trusted spaces in the community, including 2 community hubs where residents feel comfortable engaging with health services. So Slough really feels, and Slough gives us both the scale and the complexity to test what neighbourhood health can really do. And that's why we've been successful as one of the pilots under the National Neighbourhood Health Implementation Programme pilot. So one of the first things we did with Frimley ICS was agree what we actually mean by neighbourhood health. It's not a project or a reorganisation, it's a way of working that links population health data, community engagement, and operational delivery. It sits between public health and frontline services, connecting the intelligence of data with the lived experience of people. And it's that clarity that has helped us build a shared language across partners. So in Slough, we've connected all 6 elements into one coherent neighbourhood model. When I say we've connected, we are connecting. That's the process and that's the journey we're on. As I said, from a population health management perspective, we're using connected care to identify people at risk of things like frailty, or looking at our proactive diagnosis cohorts. In terms of our neighbourhood teams, we already have in place a model blend of community clinicians, including GPs and social prescribers, around shared caseloads. And we have a very strong community services delivered through Berkshire Health Foundation Trust with consistent neighbourhood alignment. We have intermediate care through Home First and virtual frailty wards, bridging this acute and community. And as mentioned, model general practice is a massive part of what we do in Slough. We have digital access to our online consultation providers, as well as our telephony and cloud-based systems, and as well as using connected care for proactive diagnosis in order to achieve that left shift. So we call it integration, not addition. It's 6 moving parts with one shared purpose. So what we really feel is that integration happens between people and not logos. In Slough, neighbourhood health comes to life through our community hubs, and these are trusted spaces which are our anchor for our pilot. So co-locating the NHS, council and voluntary sectors together. And it's trusted spaces where prevention and early intervention happen side by side. We've turned clinical monitoring into community engagement, and anecdotally we can say HbA1c levels in some of our high-risk cohorts have actually reduced, partly because people are coming to these trusted physical spaces, these hubs, for informal community appointment days rather than clinical clinics. And it just shows how trust, place and culture can literally improve outcomes. So as I said, integration happens between people, not logos. And in Slough, our leadership has been shared between the ICB, the council and our community providers through something called our Better Care Fund governance, or Better Care Fund and the governance framework around it. The focus now for us is on collective behaviour, so it's aligning finance, aligning data and purpose. And at our last meeting, we discussed moving from siloed funding to shared investment, using, for example, developer contribution as an example of something we'd like to explore. Section 106 funds and neighbourhood planning to help sustain that local model. It's about putting population before organisation and moving money where the flow of care actually happens. And that's the big shift that we hope to achieve. We're already seeing results, so blood pressure control, reduced A&E attendances, lower HbA1c levels through that combination of community-based engagement with population health management. Faster decision-making can be done, and it has been done through our integration with connected care, and stronger community trust and awareness through our hubs. But the biggest result for us is cultural. What we're seeing through this process is we're seeing curiosity and humility replace bureaucracy. Teams are asking, why doesn't this work and how do we fix it together? And for us, that's a huge shift. So lastly, just to wrap up, for us in Slough, neighbourhood health, it isn't a project, it's a movement. It's the NHS rediscovered at really its most human scale, local, connected, proactive. And when we align around one population, have one purpose and one shared data set, that's where we stop talking about integration and actually start living it. And that's the journey that Slough is on. So, thank you. I'll hand over to Kamal.
Thank you. Oh, what's happened here now?
You got it?
Is it sharing okay? Perfect. Okay, so hi everybody. My name is Kamal Bahia and I work in the Southeast region for NHS England. I just want to take a couple of minutes of your time to share a tool that we've been developing in the Southeast region with our community of practice and stakeholders. This slide gives you a little bit of information about it, so I'm not really going to go into much detail on that. But really, the essence behind it is that it's a self-assessment tool. You can use it if you're thinking about where you are with neighbourhood working, if you're in a team, if you're in an organisation, it's fully flexible for you. We're on version 6 at the moment, and this is a work in progress. As you can see along the top, the blue 4 boxes are emerging, developing, maturing, and embedded. And they are taken from the social prescribing matrix, just because I thought they fitted this space really well. And why reinvent the wheel if there's something out there that works already? And believe me, I did look for a neighborhood one already, but there wasn't. So that's why we've developed one. And then we came up with 6 domains to think about shared purpose, thinking about that leadership space, thinking about the people working and what does that feel like, what does it look like, thinking about your assets, also about the population. Obviously, health inequalities is a big thing, and we need to be making sure we're reaching the areas we need to reach, but using data to inform that, but also the voice of your local communities and people. Thinking about personalized coordinated care. Personalized care was introduced quite some time ago now and is business as usual for some people, but not all. But let's make sure it's embedded and people are actually receiving the care plans and that joined up care that they really should be getting. We've been doing quite a lot of work on embedding communities thinking into neighborhoods, and the section that we've got on here is the one that we've landed on at the moment, but we've done quite a lot of work in the background with another task and finish group, and hopefully that will come out later this year so that we can inform that a bit more. And then it's really important to think about your workforce and how that education, learning, and culture impacts on it. There's a second page to the matrix. One is a section on reflective questions, so things that you might want to ask yourself before you complete it. And then there's a section here on suggested evidence. And I'm thinking, Claire, the examples of metrics that you put on the slide you put on early on, perhaps we should combine the two, because when I was developing these with the group, we were thinking, what might you need to show evidence to other people, not just to yourself? I've got a pastel coloured version of this, and the reason why I've included that is because that links through to some case studies that we've got, and I've retained that because on the future site we have categorized the case studies against each domain. So if you're thinking you've assessed yourself and you want some more information on how to work with people and communities, then you can look up that section in the future space. There's a link to the future space here, a link to the regional website, and I've got a bigger presentation that Claire can share with all of you afterwards. But thank you very much. I'll hand back to you.
Thank you very much. That's really useful. Thank you. What I'm going to do now is I am going to just skip over these next 2 slides because it's been mentioned we do need to consider digital inclusion, exclusion. Obviously, not everybody has access to digital solutions, so we need to keep that in mind. And then thinking about the first cohorts that you would like to approach. So just a note here, start small. Don't do everything at once. So nobody's asking you to do everything at once and create a whole neighbourhood system overnight. Think about what you're already doing. As Alice said before, there are things set up in your PCNs already that are easily scalable to neighbourhood working. So just have a think about what has the most potential impact for your area. You've probably got a really good idea about what that is anyway. But I'm going to pass over now to Anita Howard, and she is from Cambridgeshire and Royston, South Cambridgeshire and Royston, and she's been working in a neighbourhood for the past few years with some really positive outcomes. So over to you, Anita.
Lovely. Hopefully you can hear me all okay. So yeah, I've worked in the neighbourhood way of working for a good couple of years now. And what I wanted to really do is just share a little bit about a project we've been working on. And I'm starting off with this slide just as a kind of placemaker, just to say that, like a lot of the other speakers have said already today, it is about overcoming organisational boundaries and physically bringing teams together around a community's health. But secondly, and perhaps a little bit more importantly, it's about developing a way of working that becomes less about process and a bit more about people. And I know I'm very much preaching to the converted on that one, I'm sure. But it's important to say that in the outset, just to set the scene for the project I'm going to talk about, because it was a little bit more about a culture change piece than a process piece. So let me tell you a little bit about the project. So it's called Proactive Neighbourhoods, and the cohort was very much residents not yet at the threshold for statutory services. So that already brought it across as a system issue. It wasn't just about health, it was about all sorts of people that were a worry, keeping people up at night, really those kind of people that you know that need a better outcome. So it was launched in June 2024. It was a local response to the ICB's Tier 2 High Impact Users project. It's based in South Cambridgeshire, and it was actually co-designed with people working within the workforce. So it wasn't a project that was introduced. The outcome was shared, and then it was designed amongst all the people that were working there. And ultimately, we wanted to move away from that reactive silo kind of system response to some of the, to try and improve those long-term outcomes. So as I mentioned, it was people at risk of becoming high impact users of the future. So it was, generally seen as a bit of a gap in our system. There wasn't a lot of support for people there. We almost had to wait for them to get a little bit more poorly, a little bit more in crisis before we could actually step in. So yeah, basically it's all about trying to get the whole system working better together. Any professional supporting a resident in the locality can bring a case forward. I would say about half come from social prescribers and community matrons based in primary care. Some come through our quite successful Work Well programme that's helping people remain or get back into work. But some come from our community safety partnerships, so come from a very police aspect, or we also have good connections with our housing officers and housing associations, along with more community-based roles like mobile wardens, village agents, community navigators. They're different names in different systems, but we all know those kind of roles. So Proactive Neighbourhoods is really, it's about a personalised approach. So using the what matters to me kind of conversation, what we're trying to do is develop those personalised care plans in a much of a longer term process. So we're, instead of thinking what is important to the system, we start to have those conversations really early on around what is important to the individual, and then co-designing that personalised plan with them. That personalised plan can be connected across a number of different organisations. It doesn't just have to be a singular organisation. And another really important aspect for us is making sure that we're picking up on some of that impact. We know the impact's great for individuals, but it's notoriously very difficult to measure that. So we use MyCore, and it's one of the requirements of the project that everybody has a MyCore at the beginning of the support and at the end of the support too. So the other aspect is the math. And this is about a multi-agency gathering. Now, it's trying to find the right way of describing this, and it's really hard because it's not the same as an MDT. It's more about a bit of peer support. It's more about bringing professionals together. But what we can do is we can have that dual approach to supporting the individual cases that come up. So a little bit of reality check. our goal was really simple, to have neighbourhood health and wellbeing care become a reality, and not just about being a policy document or a tick box exercise. It wasn't about how many personalised care plans we could produce and how quickly. It was about how can we better support those in the community that we're most worried about. So yeah, generally there was a fair few inherent barriers for us to do that. And I think it is sort of important to know that the vision and the reality isn't always that smooth running. You know, what we had to do is deal with some of the siloed data, different IT systems, separate governance structures, and, you know, varying professional cultures. And by that, I mean, it's, you know, whether people have permission to work in this way, whether they feel comfortable with it, lots of things like that to just bear in mind. So just to probably labour the point a little bit, but I think it is important. We want to be really open with the challenges that we faced. And, you know, it sounds a little bit twee, but treating those failures as, you know, a little bit of an opportunity to learn and develop, so our system can continually evolve and get a bit better. So there's 5 specific barriers that we tried to bust early doors, and I wouldn't say we've nailed them all entirely, but I think we've made really good progress as a collective. We did some real workarounds, and I think that's important to recognise that through that you do start to find more permanent solutions to some of these big problems. The biggest one, and the one I'll probably talk about more in the slides, there is a bit more notes on all the others, but it's the shared system barrier. Waiting for a shared system across all our organisations was going to take years. It's not going to happen straight away. So that we knew that stopping the project to wait for that was not going to be an option. And the workaround is pretty simple, really, and quite immediate. We basically asked all professionals to come to the MAF, our multi-agency forum, with their laptops or tablets. And we basically said that with this, it allows us to use their own security systems to access their data about their clients, but just happen to be in the same room at the same time. So this enabled us to have kind of facilitating that joint decision making, really. You know, it kind of moved it from we can't share any of our data to we can look at each other's records. We can, you know, come up with a plan together because we can access each other's information. Of course, it only works if there is patient consent, and that was another of the barriers that we had to work through. You know, it was a lot harder to get the consent than we first anticipated. And when we started to dig that in with the workforce, we found it was more about a comfort with asking the question, not an actual uncomfort from the patient to share the data. So it is important to pick that up. So we've basically refined our workflow to make sure the appropriate professional is asking early on if the data can be shared with named and selected other organisations. Just very, very quickly, just to pick up a couple of points, professional trust. We did a lot of work around relational ways of working, which I know other speakers have mentioned as well. So we have our very popular SKIP, badly named, very popular partnership. SKIP is all about bringing people together. It showcases different parts of the system. It helps people get to know names and faces and understand what's important to other people, which is really great for starting to build that professional trust up. We have peer support groups for anyone working in the system, working with different people. And also, you know, in terms of case identification and monitoring, you know, we're bringing people together. Only yesterday morning, we had a deep dive into how we can better code, how we can better be proactive about pulling up the right kind of cases. So it is about changing that way of working and really trying to bust those barriers in the simplest and easiest way possible, because if you don't, there's never going to be that progress made. And actually, although numbers are a lot smaller than we ever hoped at the beginning of this project, what we know is the quality of care has been massive for those people, a real step change. And as well, you know, we're seeing the numbers like grow month on month as there's more confidence in this way of working. So just as in terms of my key kind of takeaways. And again, I just have to say this is a little bit of an oversimplification of quite a complex project that had to learn and twist along the way. But if you don't start, it doesn't start. You know, we had to start small. We found it was much easier to bring people together and go on that journey together than it was to impose a project. And the way we tackled it was just find our first barrier and find a workaround for that, and then we'll work on our next barrier and work on that. And it just makes it a lot more well, it gives a project the opportunity to grow into something quite special. So yeah, very happy to connect with people outside to share a little bit more of the warts and all of our project that we are very proud of, and we do think is making quite a bit of a difference to our local community. So yeah, I will hand back.
Thanks, Anita. I think I hop in here at this point, and it's really just to kind of flag. I think when it's hearing those and going back over what we've heard a little bit from our speakers, is that in understanding what the kind of the national aims for around the components of a neighbourhood, thinking about starting small and really focusing on building the relationships, understanding the different organisations that will be coming together and working together, is so fundamental, because we know from the 10-year plan, we know from the conversations and how things are progressing, that we have got to prepare for things to feel a bit more formalised. And as I said earlier, there are pilots running nationally now where they're starting to look at how to turn some of these local ways of working, these really successful approaches that are playing out on the ground, but not necessarily in a consistent way, but trying to now think about, well, how can these be formalized? How can there be more formal arrangements around the kind of the contracting and the funding flows that go through neighbourhoods, and that will enable neighbourhoods and that out of hospital space to flourish. So and I think that's going to be a really tricky shift, because often something that that damages the work that's been done around the relationships and the coming together is then trying to put a formal contract around it. So I think we all wait with quite bated breath, really, around what the kind of the contractual implications that might be. That might follow when we look at this. The 10-year plan talks about the single neighbourhood providers, so contractual arrangements for around 50,000 populations, and those bigger multi-neighbourhood providers, so arrangements covering populations of over 250,000. We don't know the details of that yet. We don't know what will happen to existing contracting arrangements that support collaboration, so things like the PCN, Directed Enhanced Service. But we know that when these new contract vehicles are tested and when they start to become part of our infrastructure, then we know that it's going to have an implication on some of the way that funding flows and that and how services are currently resourced. So we'll go into this in more detail, I think, in some of our later sessions, and as the learning and some of the information starts to follow. But I think as we're looking through, and we're looking through from this perspective of the kind of the collaborative and the integrated working, it is gearing up towards something that will start to feel more formalized, and having an eye on that and having a view to how that might alter what's happening on the ground is important to bear in mind. So we're already seeing it and thinking about some of the financial considerations and how that might impact on things like general practice funding, or it might impact on how pilots and projects have currently been funded. But we're seeing that because ICBs, we know they're coming together on much larger footprints, and there will be pressure for those health systems to look at perhaps what works well in one area and think think about how that's implemented or rolled out across another. So changing things that happen and that are kind of familiar on the ground. As I said before, the new neighbourhood contracts that come in will have funding flows attached to them that we don't know how that looks. We also know that this rollout and this approach to neighbourhood working isn't coming with a big cash injection or big access to resources, and it's going to come from people working together, understanding their assets, understanding the funding that's already in place, and looking at how that's used differently. So that will change some of the conversations around local discretionary funding that ICBs invest or that local authorities invest, and it might also change how services are commissioned on the ground. And kind of with my particular interest in general practice, that leads me to think about, well, how will it change things like local commissioning, local enhanced services, and the impact that has on individual practices. I think as these contracts start to become clearer in terms of their intention and what they're going to cover, we know that's going to take time. It's going to take time to embed. So we'll see more happening in kind of more pilot. I still think we'll see more pilots, we'll see more projects, we'll see more collaboration between providers to facilitate some of that shift, be it left shift, which we hope, into that out of hospital space, or just a realignment of how resources are currently used, and that might be through kind of existing collaborations or subcontracting arrangements. But I think it's just important to have an eye on those, have a start to think about what that might mean, and how as individual organisations you're positioning yourselves so that you know that you're party to those conversations and can have some input and some shaping into how that might look on your patch. We're conscious that you've listened really, really intently. I'm going to pass back to, I'm just seeing who I'm going to pass back to.
It's me.
Back to Claire. Let me let you
Thank you very much.
Control. But we will pick up on this later.
Fabulous. So coming back to the beginning of the session, and that we are talking about sort of foundations of integrated neighbourhood teams and how ready you feel you are. So I got the poll from before, which we got an average of 2.4 as to the understanding of what is expected from you in general practice or PCNs. So we are going to be giving everybody today a readiness assessment from our D&T hub. So this is for you to do between now and the next webinar. So you can identify any gaps or areas that you might need to think about in more detail. So the D&T hub will take you through a short maturity assessment for digital and transformation before giving you the option to complete this neighbourhood readiness assessment. It sits in our workforce and leadership pillar. If you'd like to take the assessment but you're not part of a practice, we will send out a version of the assessment that you can fill in. Having a nod to Kamal's maturity assessment, which you will be able to use when you're a bit further down the line, when you've got a programme, when you've got a project, and you're able to then look into it. This readiness assessment will give you some ideas on what you need to think about now. So I'm conscious we need to come on to the Q&A. So I welcome back Kamal, Bharam and Anita. Are there any questions in the chat that we can pick up? I know, Rachel, you've been popping comments in the chat. Yeah, someone said you can add NHS app as a baseline. That's fabulous. I am just going to make sure that everybody's mics and cameras are allowed. So if you do have a question and you'd like to pop your hand up and ask it, feel free.
There's one question about devolution and dentistry. And I think in terms of, because some of the areas are still evolving, and certainly in the southeast, I think it's going to be another couple of years before we see the full effect. But one of the things that we've heard and seen is that health and wellbeing boards are going to be developing neighbourhood plans. So there will be linkages all the way through. And dentistry is included. I don't know why you got the impression that it wasn't. We may not have mentioned it today, but certainly I've been talking with dentists who are doing some amazing stuff with care navigation, for example.
Fabulous. Thank you. I can't see any more questions in the chat.
There was one about, it wasn't a question, it was about voluntary service and funding. And I think that's definitely one I've heard from lots of areas. And I'm working with our Department of Health and Social Care colleagues to look at how we are working with the voluntary sector and community sector and what we can do to support that. Definitely there is a push about longer term contracts, and we're hoping once the planning requirements come out that we have got that this year, but until we see it we won't be able to say.
Okay, thank you.
And if I can just add to that, I'm working with one of the London boroughs through the voluntary community faith sector, and it's really working with them to ensure that the voice is at that table. At the moment, there seems to be 1 or 2 voluntary and community sector leads, if it's particularly sectorised and rather than across, and actually getting the very small organisations who do great work to actually start collaborating to be able to look at what's expected of them, how can they actually have that voice, looking at the wealth of data, the trusted relationship they have. The huge part of neighbourhoods, absolutely, they have a lot of data that needs to be fed into this as well. They are the voice and the heart, the beating heart of our community. And making sure that when the asset mapping's done, that the funding flows are included throughout to make sure that we spend our pound effectively, I think. But I definitely think there's a lot more work to be done drawing our voluntary sector in. There's a question about the pace that this is working for our voluntary and community sector as well. Mm-hmm. So I probably think there's, from just my experience of working with some of my colleagues in this sector is there's more work to do, most definitely.
Thank you. I can see Tracy, you've got your hand up.
I have, yeah. I thought I'd better speak as I put a lot in the chat. Thank you for that. Yeah, we know that there's some discussion going on around longer term contracts, etc. And I just wanted to say that, for instance, our organisation is an infrastructure organisation and we don't get funded for that kind of work. So being sat here today, our organisation is not paid for me to be here, but we need to be in these kind of discussions. And as an infrastructure organisation, the little groups that are solely volunteer run, like Anita Nata groups, etc., that are so valuable in the community, they don't have time to come to these things. So we take it upon ourselves to be their voice. So so it's not just about the money, it's about the capacity and the ability for people to come along to these kind of things and be sat around these tables and have their voice heard. So I thought I'd better speak.
Thank you for that, Tracy. And I think if we're doing it right, they shouldn't have to come to us. We should be going to them and working together. So, invite me to any of your meetings. I'm happy to come and talk there.
Fabulous. Thank you. I can see there's been a couple of questions in the chat and I think we've covered some of them. There's just one for Dr. Kumar. About, you mentioned informal community appointments taking place in community spaces. What do those appointments involve? Could you give an example? Don't know if you're there, Dr. Kumar.
Can't see him on the call now, Claire, so we might have to take that offline. Oh,
sorry, I'm here. Yeah. What was the question? Sorry.
So you mentioned informal community appointments taking place in community spaces. What do those appointments involve, and could you give an example?
Yeah, so for example, I'll give you a real clinical example. So one of my colleagues is a diabetic specialist GP. He's had people with HbA1cs of 145 not wanting to go on insulin, but just by engaging with the voluntary sector in the hubs, because what the voluntary sector have done is put out exercise classes and conversations around diet. Just from going to those classes, from engaging, from having conversations about diabetes, what he's seen was in 6 months, in the last 6 months, our HbA1c has actually dropped to the early 100s, and he hasn't been able to achieve that in the last couple of years. So, as I said, the feedback is very much anecdotal and it's on small scale, but this is the type of thing that we're hoping to see over time at scale results when we engage with the voluntary sector. We are very, very grateful, actually, and we're very blessed in Slough to have such an engaged voluntary sector who want to work with us. And so the hubs are going to go from 2 to 4. And we call them hubs, I mean, again, trusted spaces where people can come and engage with services, because what we found on a bit of a wider conversation, I just digress, what we found is lots of people were attending general practices, and I'm sure it's around the country, for stuff that isn't really for doctors. So, you know, joint ventures of using our AR staff with a community and the voluntary sector can produce these trusted spaces that relieve the pressure on medical services, but still manage to produce some tangible outcomes.
Thank you very much, and I hope that answers your question. We do have a few more questions in the chat, I think, but we'll have to take them offline. We'll dish them out to our speakers and get some answers for you and provide that in the comms that we give you after this webinar. Just to remind everybody that this is the first of a 3-part webinar series where we will be going into more depth about all of the different aspects of neighbourhoods in the next 2. I will pop the links into the chat again for you all. Let me just do that. There we go. So if you haven't registered, you can sign up there. If you register for the next session, we'll also be offering out our INT readiness toolkit as well, which will be part of the D&T Hub offering. Apart from that, we welcome any feedback that you have from our session today. It really helps us to build our next sessions, to know whether we've hit the right audience, whether we've hit the right spots, if there's anything that we're missing. And the bonus is that if you fill it in, you go into a draw to win a £25 Amazon voucher. So it's worth filling in. It's worth a few minutes of your time. But I would just like to say a huge thank you to all of our guest speakers today. It's been fantastic having you today. Thank you very much for your insights. I'm sure people have found them really useful and informative. But yeah, thank you very much for joining. If you do have any questions, you can pop them in the chat and we'll pick them up and we'll get them out to you at some point. But thank you very much for joining today.